On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speakers from the Atrial Fibrillation Clinic at Boulder Heart. Cardiac electrophysiologist, Dr. Maria Anderson. Interventional cardiologist, Dr. Srini Iyengar, who is the structural heart director at Boulder Heart. And cardiac electrophysiologist, Dr. Oussama Lawand. The AFib Clinic at Boulder Heart provides a centralized entry point into the only full-service cardiology program in Boulder County, providing everything from diagnostic tests to advanced treatments to cardiopulmonary rehab. Boulder Heart also offers one of Colorado's most sophisticated facilities for diagnosing and treating heartbeat irregularities. Our electrophysiology lab is equipped with advanced technologies such as transesophageal echo, Cardo 3D mapping system, and intracardiac ultrasound. Welcome to tonight's speakers.
Good evening, everyone, and thanks so much for signing in. I'm Dr. Maria Anderson, and tonight we're going to go over atrial fibrillation, a very common and challenging rhythm that we see every day in our clinic. The things I'll talk about are, first of all, what is atrial fibrillation? What are its causes? What things do we worry about when people have atrial fibrillation? Then we'll talk about the treatment options for AFib and how we prevent stroke in the setting of atrial fibrillation. This is a picture of the heart. As you see, it's a complex structure. And the main thing I want to point out is that in many locations in the heart, blood vessels are coming into and out of the heart, taking the blood from the body to the heart, from the heart to the lungs, back onto the heart from the lungs, and then outward to the brain and body. And one rhythm thing that we know is that wherever a blood vessel enters or exits the heart, AFib or other arrhythmias can start. When we simplify that diagram, we see that the blood from the body enters the heart through a blood vessel, and then it moves out to the lungs, where it then, through another blood vessel, comes into the upper chamber on the left, and then out to the body and the brain. Atrial fibrillation is a rhythm that consists of chaotic electrical activity in the two upper chambers of the heart. That then creates an irregular response in the two ventricles. Most AFib starts in the left upper chamber or left atrium and then conducts quickly to both upper chambers. There are triggers for starting atrial fibrillation within the chamber itself, the atrium. And then there can be what we call substrate, where the atrium then allows this chaotic electrical activity to perpetuate. This picture is looking at someone from behind them, as if they had a see-through back. And this chamber is the one where most AFib starts. As you see, there are four big tubes or blood vessels. Those are the pulmonary veins, and they bring the oxygenated blood back to from the lungs into the heart. This is the chamber where most AFib starts. And this picture is if we were looking at someone from the front, and this is that same left upper chamber. When we again look at the left upper chamber from the back, this diagram, these red stars and blue stars, are a variety of locations where AFib commonly triggers. Right here, where these four veins become heart muscle or heart wall, are the most common spots. But these little blue stars, in this case on the back wall of that chamber, and in another vein on the heart, and then two other veins on the other side or right side of the heart, all of those can start the trigger that it becomes atrial fibrillation. An important aspect of AFib is that it worsens over time. The more AFib someone has and the longer their heart is in it, the more abnormal the upper chambers get, and then that worsens the process of AFib. The stages of AFib are first what we call paroxysmal or episodic. That's an early stage where AFib comes and goes on its own. After paroxysmal AFib, people generally develop persistent AFib. That's a middle stage where atrial fibrillation persists or lasts until we deliberately reset the heart with a procedure we call cardioversion. Long-standing persistent AFib is AFib where the person's heart has stayed in AFib for more than 6 months at a time. The final stage of AFib is what we call permanent atrial fibrillation, which is AFib that's lasted so long and has changed the upper chamber so much that the patient and their heart rhythm specialist believe that the heart's not any longer likely to go back into normal rhythm, and we stop trying to get it to go back, and then we just work on treating the symptoms of the AFib. This is a complex slide. The gist of what I want to show is that at the early stages of AFib, the heart can look normal. This is a kind of model we make of the heart, and suffice to say that purple is normal-looking tissue. As AFib gets worse, the more AFib people have, the longer it lasts, you stop seeing as much purple tissue and more of these other colored tissue that represents areas of this upper chamber that are scar. In addition, the chamber itself starts getting bigger and bigger and bigger. When that happens, and as you see here, these are kind of pathology slides where it shows that the fibers of the upper chamber start spreading apart, scar gets in between those, they get off angle to one another, and the electrical conduction is no longer smooth and regular, but becomes chaotic. When this happens and the heart starts stretching out, in addition to there being triggers, as you see here, where these veins dump into that left upper chamber, you can also, if you were looking at the outside of the heart, again, from someone's back as if they had a transparent back and you could see straight to their heart, you can get electrical triggers from the outside of the heart. When that starts to happen, the rhythm gets even harder to treat. It becomes more like a game of three-dimensional chess. At first, electrical signals in the heart should just smoothly conduct over as if it were a playing board. But when the heart starts getting diseased and stretched, the electrical signals can go from the outside in, from the inside out, and that just makes for a much more complex, difficult to treat situation. In this picture, it's confusing to look at, but suffice to say, in the normal scenario, the outside, which is this panel, and the inside of the heart, the electricity just smoothly conducts, and that's how the colors in this panel and the colors in this panel match up exactly. When AFib lasts longer, the outside of the heart and the inside of the heart conduct at different times, and that makes AFib more complicated. We diagnose atrial fibrillation usually with an EKG. A normal EKG shows the upper chamber beating, a little tiny blip, a larger blip where the bottom chamber is beating, and a smaller blip where the bottom chamber recovers from its heartbeat. The beats are evenly spaced and very regular. In atrial fibrillation, you no longer see the upper chamber beating. It's just shaking chaotically. And that makes the bottom chamber, the larger spikes, have a variable distance between them, and the heart rate is irregular and can often be rapid or even too slow. People often ask what causes atrial fibrillation? What can they do or change to make it a little bit better? Well, the bad news is that even 1 drink of alcohol a day increases a person's risk of atrial fibrillation. Tobacco use multiplies by a factor of 5 a person's likelihood of having AFib. High blood pressure is a very common risk factor for atrial fibrillation development. Sleep apnea is a very important one, in that about 85% of people who have AFib also have sleep apnea. So very commonly, an AFib clinic will refer people for evaluation of their sleep apnea because treating the sleep apnea can also help treat the AFib. Folks with heart failure or a weak heart for any reason are much more prone to develop AFib, and that's in part due to the fact that the chambers of the heart start enlarging, and that makes AFib more likely. People with disease of the valves of their heart, or the doorways between the rooms of the heart, whether those doors are too tight and don't open well, or too leaky and sort of flop open, either scenario can lead to stretch and overload of the chambers. And once the upper chambers stretch out, AFib is prone to develop. Obesity, which is tied into high blood pressure and sleep apnea and heart failure, increases the risk of AFib. And then one area that's particularly common in Boulder County is intense exercise. We'll talk more about that in a minute, but especially intense cycling, Nordic skiing, distance running, triathlons, ultra runners are much more prone to AFib. Exercise has what we call a U-shaped curve in relation to the development of atrial fibrillation as well as other heart problems. On the left-hand side of this slide, you see when people are sedentary and find themselves unable, for whatever reason, to exercise, they have a much higher likelihood of developing AFib. As people are able to exercise moderately, say 2.5 to 5 hours a week, and that can be walking, cycling, jogging, their risk of developing heart abnormalities, including AFib, drops to its lowest point. And then on the right side, when people have a very steep, intense increase in their exercise, going all out, many hours a day, every day, cycling uphill, racing a lot, running 50, 100-mile races, competitive Nordic skiing. Those folks get a lot of heart problems, and one of the main things we see in highly trained athletes is the development of atrial fibrillation. There are three things in general that we worry about with atrial fibrillation. The first is symptoms. Fatigue is the single most common symptom people have when they have atrial fibrillation. Second to that is the feeling of palpitations. What we mean by that is when people describe that their heart just isn't beating right. It's pounding, it feels irregular. Not everyone has palpitations, almost everyone does have fatigue. The second thing we worry about is the development of heart failure. When AFib is present with a fast pulse, when it makes the pulse about 120 beats a minute or more, and that lasts for weeks on end without people realizing it, it can actually weaken the strength of the heart. So we really want to try to treat AFib before it gets to that kind of point. The symptoms of that are people show up with shortness of breath, and in particular, they can't breathe when they try to lay down at night and need to prop themselves up. That's a classic sign of heart failure. The third thing we worry about is when atrial fibrillation develops and the upper chamber is just shaking chaotically, the blood can pool in that chamber and form a blood clot. If a blood clot forms and gets shot out of the heart to the brain, that's what a stroke is. So we assess each individual person's risk of stroke through a score that I'll talk about a little bit more in detail. Mitral stenosis of the valve disease, mitral stenosis, is also a very high risk of, creates a very high risk of stroke, as does correcting mitral stenosis with a mechanical heart valve. And that requires lifelong anticoagulation with the medicine Coumadin. This is what mitral stenosis is. The doorway between the left upper and left lower chambers of the heart, the mitral valve, gets scarred, most commonly from an infection, and it doesn't open as well as it should. That puts a lot of pressure on the left upper chamber and can trigger atrial fibrillation. In most cases, we use what's called the CHADS-2 VAS score to assess a person's individual risk or likelihood of having a stroke if they have AFib. So this is a score we use just in people who have atrial fibrillation. There's 1 point for folks who have heart failure, 1 for high blood pressure, When a person's age is over 75 points, they have 2 points on this scale. Diabetes gives 1 point. Having survived a prior stroke or having a TIA, what we sometimes call a reversible stroke, gives people 2 points on this scale. Blocked arteries, whether they're in the heart or the legs or the neck, that gives a point on the scale. Having an age between 65 and 74 is a point, and being a woman, unfortunately for us, is a point as well. When someone has a score of 2 or more, studies in tens of thousands of patients show that people benefit from lifelong blood thinning with an anticoagulant. People often ask what that means. Aspirin, unfortunately, has been extensively studied in this setting and is not shown, sadly, to decrease the risk of stroke. So aspirin in this setting is not considered sufficient for protection against stroke. Warfarin is the traditional medicine that we've used to prevent stroke in folks. Nowadays, we much more commonly use the easier to take medications of apixaban or Eliquis, rivaroxaban, Xarelto, or Pradaxa, dabigatran. Apixaban has the best stroke prevention on studies and the least amount of excess bleeding, so that's the one that most of us use most commonly. These medicines can be very expensive and sometimes aren't covered well by insurance, so we guide our patients in getting these medications through mail order pharmacies where they can get the generic forms of these meds very affordably. Now, if people cannot take a blood thinner for a variety of reasons, mostly because they have a high bleeding risk, we can refer them to have the area of the heart that causes the most blood clots blocked off. That area is called the left atrial appendage, and Dr. Iyengar is going to talk about that in detail. This is a picture of that. If we're looking at the front of a person, and this is the left upper chamber, specifically the left atrial appendage, which is a pouch off the left atrium. This little pouch is where most clots tend to form in people who have AFib. And Dr. Iyengar will give you some detail, but they can put in a Watchman device to block that off and prevent stroke. The reason I'm bringing up, in addition to Dr. Iyengar, is often people come to us and ask if they could use the Watchman as a treatment for their AFib. The Watchman prevents stroke in folks with AFib who cannot take a blood thinner, but it doesn't directly treat the AFib. So we all work as a team to accomplish that. So what are the treatments for atrial fibrillation? In general, we divide those into rate control, which means slowing down atrial fibrillation when it's occurring, or rhythm control, which gears at getting the person out of AFib and keeping them out of AFib. Rate control involves using medications like metoprolol or diltiazem simply to slow down the rhythm. Rhythm control involves resetting the heart, often with cardioversion, and then using either a medication, some of the common ones are flecainide, sotalol, or Ticasin, to keep the person in normal rhythm, or pursuing the procedure called atrial fibrillation, ablation. AFib ablation is the best we've got for treating atrial fibrillation, and we'll talk about that in more detail. All treatments for AFib get less successful as AFib progresses from paroxysmal, where we can tell people a fib ablation is 75% likely to keep them free from fib, to persistent, where the success is 50 to 60%, to long-standing persistent, where we only have about a 30% chance of keeping people in normal rhythm if their AFib has progressed to that point before we do an ablation procedure. Another form of what we call rate control, or just regularizing and controlling the heart rate in AFib that we use, is called AV node ablation with a pacemaker. What this does is essentially isolate the AFib into the upper chamber. It doesn't get rid of the AFib, but it prevents it from affecting the pulse. It prevents it from making the heart too fast or too slow or irregular. And that, in folks who failed other treatments, such as medications or ablation, that can be a great combination to more or less bypass the AFib and just keep the heart beating regularly and efficiently. And that's a treatment we use when other things have failed. So that's the summary of what atrial fibrillation is, what we worry about, and how we treat it. I'm going to now pass the talk on to Dr. Oussama Lawand, another cardiac electrophysiologist in our practice, to discuss catheter ablation specifically.
All right, thank you for tuning in, and I'm going to talk to you about atrial fibrillation ablation. So what we'll talk about today is the setup for the procedure. We'll talk about the method by which the procedure is done. We'll talk about risks that come with catheter ablation. We'll talk about safety measures that we take during the procedure, follow-up after the ablation, along with how we treat atrial fibrillation if it occurs after the procedure, and indications to proceed with another ablation after the first ablation. So on the day of the procedure, the anesthesiologist and the cardiac electrophysiologist will see the patient and the family in the CVC and obtain informed consent. Then the patient is brought to the room and attached to the EKGs, the monitor, and the mapping software patches. The magnet for the mapping software is set up under the patient, under the table, and the table for the access catheters is also set up. The mapping system representative will be present in the control room helping guide the team with the software for the whole procedure. General anesthesia with endotracheal intubation is used, and that's performed by the anesthesiologist at the start of the procedure. And the transesophageal echocardiogram is passed through the food pipe, the esophagus, to get a look at the left atrium and make sure there's no clot inside the heart, and that's performed by the cardiac electrophysiologist. So here we see a picture of endotracheal intubation as performed by the anesthesiologist, and then the patient will be placed on mechanical ventilation for the remainder of the procedure. Here we see a picture of a transesophageal echocardiogram that's advanced through the mouth down into the food pipe, and the food pipe happens to be located adjacent to the left atrium, and from there we can get pictures of the left atrium to make sure that there's no clot or thrombus within it. This is a picture of the left atrium, and the arrow is pointing to clot or thrombus within the left atrial appendage. If this is seen at the beginning of the procedure is actually canceled because of the very high risk of stroke with the thrombus inside of the left atrium. Femoral vein access is obtained. We do this with ultrasound guidance, and 3 catheters are inserted into the femoral vein and used to deliver the mapping to the heart. So this is a picture of a cardiac electrophysiologist, and he's standing by the patient after he's obtained access into the femoral veins. This here is a picture of the ultrasound probe over the right groin, and the ultrasound probe allows us to see the femoral vein and the femoral artery in real time. And with this modality, we can actually make sure that the femoral vein is clear when we stick it to make sure there's no injury or damage to any structures around the femoral vein to minimize the risk of collateral damage. So 3 catheters are advanced through the femoral vein and guided to the heart. The first catheter is the mapping catheter that's advanced through a sheath. And then once the mapping catheter has been advanced to the heart and the mapping has been performed, it's exchanged for the ablation catheter, which is used to perform the actual ablation. A sheath is also used to deliver a catheter into the coronary sinus. And this catheter is placed in the coronary sinus and used for recording electrical signals and for stimulation. And lastly, a third sheath is used to deliver an intracardiac echocatheter into the heart. And the intracardiac echocatheter allows us to have real-time ultrasound imaging within the heart to guide the whole procedure from start to finish. So this is a picture of the heart from behind, and you can see the coronary sinus here, which is the vein that wraps around the back of the left atrium, and it provides a stable location for a catheter used for stimulating the heart and recording electrical signals for the entire case. This is a picture of an intracardiac echo catheter, and this catheter is used to obtain ultrasound guidance within the heart. It's used for helping us guide the catheters in the heart and also used to detect any kind of issues like a pericardial effusion, which we'll talk about later. It's a great way to make sure the procedure is done safely. The anesthesiologist will also place an esophageal cooling probe at the start of the procedure. This probe is passed down into the esophagus and is used to prevent any thermal injury to the esophagus. The esophagus, because of its location behind the left atrium, can sustain thermal injury, and in severe cases, this may lead to an atrioesophageal fistula. This is a rare but fatal condition, and the esophageal cooling probe can help us prevent significant damage to the esophagus. And this is a picture of the esophageal cooling probe having passed through the mouth down into the esophagus, and it is cooled down to 4 degrees Celsius before ablation on the left atrium is performed. This is a picture of an intracardiac echo image. The intracardiac echo catheter is parked in the right atrium, and it is used to actually guide the transeptal puncture that we need to do in order to deliver the mapping catheter and the ablation catheter into the left atrium. This here is a picture of the radiofrequency wire that we use to perform the transeptal puncture. This wire and the provided sheath allow us to perform the transeptal in an extremely accurate way in order to make sure that it's done very safely. This is a picture of the mapping catheter that we use to create the electrical geometry of the left atrium. It has 8 splines, and it's very atraumatic and allows us to move the catheter and obtain the geometry in a very safe way. This here is a picture of the back of the left atrium, and this is the electroanatomical image that we create using the mapping catheter at the start of the procedure. And here you can see the 4 pulmonary veins that we target during the ablation. This is a picture of the handle of the ablation catheter, and as you can see, there's a knob there that allows us to bend the catheter forwards and backwards so that we can achieve precise ablations as we're ablating around the pulmonary veins. And this here is a picture of the electroanatomical map of the left atrium. We're looking at the left atrium from behind, and we can see here the ablation catheter being used to perform ablation in a point-by-point fashion around the pulmonary veins. We do this in order to isolate these pulmonary veins electrically from the rest of the heart. By creating a scar barrier, we can prevent the electrical impulses that cause atrial fibrillation from getting into the left atrium and controlling atrial fibrillation in that way. We encircle all 4 pulmonary veins with the ablation lesions in this manner. In some patients with more advanced forms of atrial fibrillation, we end up performing a posterior wall isolation. It's depicted in this diagram. We essentially ablate the area between the pulmonary veins on the back of the left atrium and isolating that entire area in order to control AFib. This is not done in most ablations, but in some ablations we end up having to do this in order to control AFib. This is an echo image of a heart, and surrounding it there is fluid. This is what we call a pericardial effusion. If this is identified during the procedure, the fluid and or blood needs to be immediately removed with a needle in a procedure called a pericardiocentesis. This is one of the major complications that can occur with catheter ablation. Thankfully, this is a very rare complication, and using the technology that I've described, we can minimize the risks of this. At the end of the procedure, the catheters and sheaths are removed, and the tiny little hole that's left in the femoral vein can be closed using this device called the perclose. The perclose device allows us to embed a tiny little permanent suture into the vein to close off the little hole. After the ablation itself takes about 2 to 4 hours, depending on how advanced the AFib is. Patients recover for about 2 hours, so supine time on their back is only about 2 hours, and a lot of that is because we use ultrasound to gain access, and the perclose allows us to allow our patients to get up and walk after 2 hours. And then they typically will go home on the same day. After the patient goes home, they come back for a visit in 1 month with one of our physician assistants, and then 3 months later, they come back and visit with the cardiac electrophysiologist. It is not uncommon to have some atrial fibrillation occur in the few weeks after the ablation. If the AFib lasts for more than 12 hours, it's a good idea to contact us and we can help you get through it. Sometimes we have to perform a cardioversion to restore normal rhythm during this period. If atrial fibrillation continues to recur past 3 months after the ablation, sometimes we have to consider performing a second ablation. Atrial fibrillation is a complex and progressive rhythm. Avoiding causes and triggers can help, especially early on in the process. Most people with atrial fibrillation do need anticoagulation, a blood thinner, before, during, and after the ablation. And the best way in order to prevent atrial fibrillation from progressing to more persistent forms is by adopting an early rhythm control strategy, which usually involves either antiarrhythmic drugs early on or catheter ablation. Atrial fibrillation ablation is the best we have for controlling AFib. There is no cure, however, through lifestyle modification and early rhythm control, we can help control AFib and help most of our patients lead a very normal life. If all else fails and AFib continues to recur despite multiple attempts, we can adopt a strategy of permanent rate control with AV node ablation and pacemaker implantation. Thank you so much.
All right, folks, I'm going to finish it up tonight, and I thank my colleagues for opening up the session here. We're going to be talking about now stroke and blood thinning medication. What else is available? So we've talked about ablation and the causes of atrial fibrillation and how, we go about the workup. But there's one thing that Dr. Anderson had mentioned earlier, that AFib is basically a rhythm that's irregular. And the top parts of the heart don't communicate electrically with the bottom parts. And that causes basically a dysregulation or dysrhythmia. And these could result in shortness of breath, lightheadedness, palpitations. And as she mentioned previously, things that cause AFib, high blood pressure, heart attacks, abnormal heart valves, something you're born with like congenital heart defects, and exposure to tobacco, alcohol, caffeine. And one thing that's not written here is sleep apnea, which would be another common cause of these rhythms. So you have to have an EKG or ECG. The reason why is I have a lot of patients that say, I think I'm in AFib, my pulse is very irregular. It's possible, but we really need to have the EKG to show what the rhythm is, because you can have something called PVCs, APCs, these are just other terms for other benign rhythms that you can have that are making your pulse irregular. So AFib does not have to be chronic. It can be short-lasting or come and go. And so there's many different terms. Unfortunately, they all begin with P, paroxysmal, persistent, permanent. So the treatment, the medications to control the heart rate are oftentimes beta blockers, calcium channel blockers. There are antiarrhythmic medications that can be used to control the rhythm. Cardioversion, where we give you a little electricity, but you're sedated, you don't feel it. And ablation, like we just talked about. So these are ways to treat the rhythm and the symptoms elicited by the rhythm. But what else does AFib cause? Stroke. So the left atrial appendage, which is in the left atrium, can collect blood and form clots that can break free in patients with AFib. So that's why we place patients in AFib who have an elevated risk of stroke on blood thinners. So when you see all those commercials on TV about the guy running down the dock to go swimming or playing with his kids, the real thing is the reason why those commercials are there about these blood thinners is because AFib causes the top chamber to basically not contract properly. And that not contracting causes blood to swirl. And that blood swirling can end up in that appendage of the left atrium, which is what we're going to talk about a little bit later in this talk. And that is where the clot can form and cause problems later on. So blood thinners, they're excellent. They work very well. However, you have to take them regularly. You can't double up the doses and say, I missed yesterday's dose, I'm going to take 2 today. That's dangerous. You need to be on the right dose at the right time. There's a medication called warfarin or Coumadin. Hundreds of thousands of people are on this medication. It works, it's cheap. However, dietary restrictions and basically routine testing are reasons why people aren't very compliant with it. So we have medications like Eliquis or Xarelto or Pradaxa. You've heard of all these, I'm sure. The downside of these medications, they can be very costly. They're not generic. So insurance companies are charging a fair penny for these. And of course, when people ask me, well, what's the downside of a blood thinner? They make your blood thin. They can make bleeding much worse. So it's kind of a common sense thing when you think about a blood thinner. What's the real big side effects? They make you bleed easier, or they prevent you from clotting faster. So AFib is a growing problem with greater morbidity and mortality. We're seeing higher stroke risk for older patients. 15 to 20% of all strokes are AFib related, and AFib results in greater disability compared to non-AFib related strokes. These strokes are debilitating. Unlike a heart attack, which I treat all the time, the heart muscle itself, well, we know what's going on in there, and the presentations are usually quite universal. Left arm pain, chest pain, maybe some stomach pain, jaw pain. Strokes all over the place. You can have strokes that basically affect your arms, your legs, your mouth, speech, cognitive functions. So strokes cannot be, you cannot really predict how you will respond to a stroke. So that's why it's so scary for most of us to think about, well, when you have a stroke, what will happen? We don't know. Depends on what part of the brain is affected. So the guidelines have stated that we were basically going through how do we risk stratify patients. And as we mentioned earlier by my colleagues, there's a CHADS VAS score. It's kind of some way we kind of measure each patient's risk, but it's not perfect. So I'll tell you right now, I've seen patients with very low scores, maybe 0 and 1, have strokes. I've seen patients with higher scores not have strokes, not on blood thinners. So it's impossible to tell you that this is a perfect score, but this is what we utilize currently in the medical knowledge. Blood thinners, unfortunately, do carry risks. Anticoagulant therapy carries a risk of bleeding in the brain, anywhere else in the body as well. It's not because they make you bleed, but if you do have a reason to have a blood vessel break open, maybe high blood pressure, they will make the bleeding a lot worse. So we have these scoring systems, like we just mentioned, called the CHADS VAS score, which is where we kind of calculate out how someone's risk level of needing to be on a blood thinner is. And every patient with AFib will have this score calculated by your cardiologist. It's something we do routinely. We also calculate a HAS-BLED score, which we can determine how much risk it is to be on the blood thinner, how much of your bleeding risk is prevalent. So we can utilize both of these scores to kind of help us move along and figure out, well, whether or not blood thinners are adequate or appropriate for you. So bleeding risks increase over a patient's lifetime. So the older people get, the annual bleeding risk increases. Well, that makes sense because the bodies, all of our bodies, break down as time goes on. So whereas you're in your 20s and 30s, there may not be much issues. When you're 70s and your 80s, all of a sudden, there's a lot of different places to bleed, like your GI tract, your nasal, your oral pharynx. There's a number of places that you wouldn't suspect that you would start bleeding, but it can happen as we get older. So we talked about warfarin. It's cheap, it works, but why are so many people hesitant to take it? Because you have to keep this medication regulated. We call it an INR, which is a blood test that we check. Anybody who's on this medication has to have that blood test. This medication has a very narrow therapeutic window. That means if it's between 2 and 3, it's working for you in AFib. If it's below 2, it's not really working. It's above 3, your risk of bleeding goes up exponentially. So that's why this medication has to be regulated tightly, and things like alcohol, dietary, green leafy vegetables can affect the medication's efficacy. So you can actually alter the medication by what you eat. Hence, that's another reason why this medication is not very popular for a lot of people. Also though, the newer medications that I mentioned, the ones that are not generic, the ones that are expensive, well, compliance is an issue there as well. People just don't like taking blood thinners long term. And again, missing a dose is not something you can double up on later. That's not how these medications work. So despite the adoption and ability to switch to like the Eliquis, the Xareltos, or Pradaxa, adherence is still a problem with patients taking these medications. And again, major bleeding rates with these newer medications is still as high as you see with warfarin. So the thing is, what I'm trying to surmise is that AFib is a growing problem. We're seeing it more and more in younger patients, unfortunately, as well. 5 times increased risk of stroke if you have an elevated CHA2DS2-VASc score. 90-some-odd%, if not greater, come from the left atrial appendage. The current treatment with medications are effective, but many patients do not take these medications because of compliance, cost, dietary. There's a number of reasons. So we know, though, the older we all get, the risk of bleeding gets higher as we all age. So why, again, is there a connection between the appendage of the heart and blood thinning or AFib? Well, that little sac on the heart is where we've seen clot form. It's a little almost appendix of the heart, which maybe a million years ago we needed, but really clinically now, it doesn't do much for the heart or the body. So in this rock and a hard place situation, because over the last 50 years, we've been trying to figure out what do we do for a patient that has AFib, has an elevated CHA2DS2-VASc score, but has bleeding, is bleeding from the GI tract. Historically, we just took you off the medication and said, I hope you don't have a stroke. We learned from our surgical colleagues, our open heart colleagues, CT surgeons. They were actually taking off the left atrial appendage when they were doing surgery, like doing a bypass surgery or valve replacement. We learned from decades of knowledge that by them doing that, they were seeing rates of stroke reduced compared to patients who actually still had the appendage. So in interventional cardiology or interventional medicine, the thought process is, well, we don't want to go through the ribs and open someone's chest to do this. Can we go through a vein and do it without having to open the chest? But instead of clipping it, can we actually cork it off? And hence, the development of the Watchman left atrial appendage closure device. It's a one-time implant that does not need to be replaced. It's performed in the cardiac cath lab EP suite by a heart team. Transfemoral access is through the vein in the groin. It typically requires general anesthesia. It's about an hour procedure. It takes, and people say in the hospital, probably 1 day at most, rarely 2 days. So this device has been changing multiple times. I actually started planning this device back in 2015, and I actually served as a national proctor for this company to train other physicians nationally. So I've seen it from the beginning when it came out to the generation that we have now. And I will tell you, the changes of the device, if you can see the one on the left with the kind of the spikes on the bottom, it almost looks like a sea creature, that has completely changed. The newest generation device, the Watchman Flex Pro, actually doesn't have any spikes on it on the bottom. So the safety is much different than it used to be. The coating is much different. It prevents more of a clot to develop on the face of the device, which is great for patients to get off the blood thinners at 45 days. It has completely changed the game for patients who are basically not good candidates for taking blood thinners, but also have AFib. The trials of this device are legendary. I would tell you there's thousands of patients that have been enrolled in these trials over the last 20 years. It's critical to understand that because not a lot of medical devices go through this rigorous type of evaluation. A lot of devices get approved maybe on one trial and gets into clinical practice. This is one device that has literally gone through multiple trials to prove that it does reduce the risk of stroke and that it's safe for the patient to basically have in their body. So that's critical to understand that. So then one of the major trials, the PROTECT AFib trial, looked at disabling stroke reductions, and it was superior to warfarin. Now, there are arguments to say, hey, blood thinners treat the whole body. This device treats one part of the body. How do I know that blood clot can't come from somewhere else? And that is right, that is correct. But you're not getting this device as a replacement to your blood thinners. You're getting this device because you can't take the blood thinners. It's very important to remember that, because the blood thinners are a systemic medication. They treat everything in the body. This device treats one particular area of the body, which creates the most likely stroke or the most likely blood clots that cause stroke. So when patients come to me and say, I don't like warfarin, I want this device, that's not an indication for the device. The indication is you have AFib or you have an on and off AFib and you can't take the blood thinner. That would be the way we then talk about this device being utilized. So again, we're looking at the outcomes of this study. We're seeing that there's a lot less, 72% less bleeding with patients who get Watchman versus staying on oral anticoagulation therapy. And again, truthfully, we are seeing that there's numbers that are saying that ischemic strokes compared to no therapy, there's no doubt the Watchman is better. Again, though, if someone says to me, well, I want to reduce the rate of all ischemic stroke, well, blood thinners are obviously going to be a better solution because they treat the entire body. But if you are someone who has bleeding, if you are someone who has falls, you're a person that basically has trouble taking the medication for whatever reason, that would be an indication to say, well, maybe you're not a good candidate for this. You need to have the device. So again, it's the most studied device with long-term clinical data, more than anything else that I actually do commercially, what I perform. So it's quite amazing to see this type of data accrue over the last 20 years. So who do we look at as getting this device? Patients who are appropriate, we're looking for people who are bleeders, people who have fall risk, previous trauma, people who are not adequate candidates for getting their INR levels checked, who can't take their medication or afford their medication. These are people that we are looking for to say, hey, if you cannot do that, then this device makes sense. Now, if you're a patient who says, hey, I can take the medication, I just don't like it, that's not the reason to get a procedure. That's an indication for you to really understand that, you know what, I get it, you don't like it, but it's really doing some life-saving therapy for you, and then it's important for you to take it. So again, we have a really strict criteria for patients who can and cannot get these procedures. So like you mentioned, we need patients who have an appropriate rationale to seek a non-pharmacologic alternative to warfarin or any anticoagulation therapy, a history of major bleeding or falls or other issues that we've just previously mentioned, and inability to really stay compliant with your medications. If you can't get your INRs regulated or you can't afford your medications, well, this will obviously be an issue. And there's more categories opening up, one of them being occupation. I've had individuals who are living in the mountains, who are firefighters or who are working with active, big, heavy equipment. They feel like if they get a bruise, bleed in those environments, they're not going to be able to go to a hospital or medical care soon. Those individuals would be on a patient-by-patient basis, but those are people who would obviously have a real risk of being on a blood thinner. And at this point, CMS, Medicare, all insurance companies do cover this device, as long as we have the documentation of what we just discussed. AFib, an elevated CHA2DS2-VASc score, and a tangible or viable reason to come off blood thinners. So in closing, the Watchman is a safe, effective one-time procedure for appropriate patients. Once it's performed again, we obviously will follow you up 1 week after the hospitalization, 1 month, and then 45 days to get another scan of your heart to look at your device, and then at 1 year as well to make sure the device is sitting properly. Looking at this slide, from the left, which says Legacy Watchman device, to the middle, which was the initial Watchman Pro, to the right, which is the Flex Pro. You know, I'm proud to say here at Boulder, our team was the first in the state of Colorado to implant the Watchman Flex Pro commercially. And it is really quite amazing that we had the ability to utilize this device, you know, prior to a lot of other sites, because again, we are, I would like to believe, more cutting edge and we're more forward thinking. And I think our patient population deserves to have these type of procedures if they are commercially available. So with that being said, I'm going to go ahead and show you the video of how this device is deployed. And we'll see if this can play. There it is.
Here, hang on. I just need to change the display settings real quick.
I can do a Watchman. I apparently can't do a PowerPoint. So bear with me for a second here. All right, so basically what we do is we introduce a catheter into the right or left common femoral vein, usually the right side. We place a catheter that goes up a wire into the right atrium. We remove the wire and we basically perform what's called a transeptal puncture. You do not feel this and it heals over time. The wire is then placed into the left atrium. We insert a catheter into the left atrium. Once we do that, we then remove that catheter and place this catheter, which is called a pigtail for obvious reasons. We then get into the left atrial appendage, which has numerous scientific names like broccoli, windsock, and chicken wing. Didn't come up with this, someone else did. We place the catheter then into the appendage and make measurements. We then inject contrast into the appendage to assess the right size. And we're doing this under ultrasound guidance as well. So we have two modalities to look at the appendage. We then insert the Watchman. And we call a Flex Pro ball. It's basically a ball. And we deploy it. But if we don't like how it's sitting, we can retrieve it. And we can place it again, deeper, more proximal, wherever we feel that it's best suited to be placed in this appendage. Once we redeploy it, we then go through something called the pass criteria, where we try to see if it moves, if there's any color around it, what the position of it looks like. So these are all critical steps that we do for every case. And you can see there, that's called the tug test, where we're pulling back on the device. We then look at the size of the compressions, we call it, to make sure that it's sitting perfectly in the ostium. And then we look for, obviously, the seal, which is the color around the device. And if we are happy, we will then release the device. So nothing is released until we're completely convinced that the device is going to sit in place and not move. And this sealing of the front of this device will heal over time, and the body will literally absorb it. It will become part of the heart as time goes on. And we'll go back to our discussion here. And at this point in time, we will open up the floor to questions to all three of us tonight. My colleagues, Dr. Anderson, Dr. Lawand, will come on up here, and we will go ahead to the Q&A.
Thank you to all the doctors tonight. We do want to advise our audience that now is the time to submit questions if you haven't already done so. We'll take as many as we can for the remaining 35 minutes here. Try to keep the questions general if you can. And then they're going to be in no particular order. I'm just going to get started right here. Does AFib always worsen over time? I understood it could self-correct over time sometimes.
AFib, unfortunately, doesn't correct itself. When people first develop atrial fibrillation, they may go years between a first episode and a next episode. But it would be very rare for people to have just one episode of AFib and then not have it again. So it does progress over time, but the timeline over which it progresses can vary dramatically. In some people, they have their first episode of AFib, and within a year or two, they have a more advanced stage like persistent AFib. In other people, the progression can take 10 or 20 years.
Okay. Do you know the cost of the generic version of Eliquis from Canada?
That's a great question. Typically, it's about $30 a month. So that's in contrast to $1,000 a month going through insurance in the States. So we can absolutely help people get Eliquis and other medications that are blood thinners much more affordably by using out-of-country mail-order pharmacies.
Is there some risk of availability coming up with tariffs?
I don't know that any of the medications have been that will be affected by tariffs. We'll let people know if that starts being a problem.
All right, thank you for that. Is the Cox-Maze procedure still used to treat AFib?
The Cox-Maze procedure is used, but it's used in different variations by different surgeons. And so it's kind of evolved over the years. The initial surgery is a very complex surgery involving many lines that are placed in both the left atrium and the right atrium. Nowadays, surgeons have adopted it to become more focused towards isolating the posterior wall behind the left atrium. Some surgeons will still do the standard Cox-Maze surgery, which has a very high success rate in controlling AFib. However, there is a higher risk of needing a permanent pacemaker if the full Cox-Maze surgery is performed for treating AFib.
Okay. How many ablations can a person have?
There isn't really a number or a limit on how many ablations a person can have. However, generally speaking, there comes a point where additional ablation no longer gives us the kind of benefit that we need, kind of like the law of diminishing returns. However, a patient can have multiple ablations. They can have 2, 3, or even 4 ablations. And a lot of that depends on the natural history of AFib in that particular patient. And so typically that's individualized.
Okay. How do PVCs relate to AFib?
PVCs are a different rhythm, which are extra beats that come from the bottom chambers of the heart. So they're not directly related. However, the same risk factors that people have that can lead to AFib, such as high blood pressure or sleep apnea, often also predispose people to having PVCs. So it's not uncommon that we see both of those rhythms in the same person, although the one rhythm doesn't directly cause the other.
Can you please say again what a cardioversion is?
Sure.
Yeah, cardioversion is the way we can help convert AFib to normal rhythm. And the way it's done is the patient will come to the hospital and they will be sedated by an anesthesiologist, and patches are placed over the chest, and these patches are used to deliver energy to basically shock the AFib back to normal rhythm. This is a temporary reversion to normal rhythm, but it does not treat the AFib in the long run. Usually, if you've had a cardioversion for AFib, we expect the AFib to recur at some point in the future unless you're given antiarrhythmic drugs or you get a catheter ablation.
Okay. Do you recommend weaning off of flecainide when trying to get off of it rather than stopping at cold turkey?
Well, what I recommend to people is if a person would like to no longer use rhythm medications to treat their AFib or other rhythms, they should talk with their rhythm specialist, and we can come up with another plan. But to answer that question, when we stop flecainide, if we're going to either use a different medication or proceed to ablation, flecainide is a medicine that can be stopped. But you shouldn't stop or adjust your medicines on your own. You should always do that with the doctor who prescribed them. And we can give you the guidance because all the medications have different rules for different reasons. And you would want to work with your doctor to do that together.
Okay. How is it determined if a faulty heart valve is causing atrial fibrillation?
You want to
Sure.
get that one?
Well, normally when it comes to a faulty heart valve, we oftentimes will obviously listen to the patient with a stethoscope to hear something abnormal, like a murmur of some sort. But an ultrasound, an echocardiogram, which is a TTE, which is on the surface of the skin, it's not something in the mouth. We can just do this on the chest, is the first modality to really look at the heart valves. But the truth is, sometimes this is a chicken and egg scenario. You can see a valve leaking and a chamber dilating, and AFib may be present. And the question is, which came first? You know, did the AFib cause some of this to happen and the valve to leak, or did the valve leak causing the chamber to dilate, causing the AFib? So it is a little bit of a chase sometimes, and oftentimes these things exist together. So it is not a one-to-one issue. It's oftentimes we'll have to say, okay, is the leaking valve so bad that it needs something like surgery, or could we cardiovert or ablate the AFib and see how the leaking valve does? Most often the mitral valve would be the underlying etiology. So it isn't just a simple answer. It's one of those things where we would have to do some investigation, and oftentimes we may have to just say, we'll try one of these procedures, usually the least invasive, and see what happens to that leaking valve afterwards and the symptoms.
Okay. Thank you. In what way is ablation for AFib different to ablation for a flutter?
So ablation for AFib is generally considered an anatomical ablation, meaning that we understand that the vast majority of AFib triggers come from the pulmonary veins that we showed you during the presentations. And so the approach to that is to ablate around the pulmonary veins and isolate them electrically from the rest of the heart. Atrial flutter is a sister rhythm to atrial fibrillation. However, atrial flutter is a circuit that we can actually map and study in real time. Usually, over 90% of atrial flutter occurs in the right atrium in a well-defined area that we can ablate very successfully. However, there remains a small percentage of atrial flutters that can occur in the right atrium in other areas, or even in the left atrium, which need a dedicated map to be performed first before we can ablate them.
This person has had dysrhythmia since they were in their 20s, primarily PVCs, PACs. They developed SVT in their 50s and AFib in 2019. They're on the sofa. They've been told that they have some heart failure now that is not due to cardiomyopathy. Could ablation help with these dysrhythmias that this person has?
There's so much detail that we would really appreciate someone like that sitting down with them, going over all the testing that they've been good enough to go through over the years to see what the options are for treating their various symptoms, et cetera. So it would be difficult to answer that question in this kind of setting.
Okay. Well, hopefully they'll contact you
Yeah.
guys and come in. This person thinks that there is contradictory info for aspirin. Is aspirin helpful for preventing stroke for a person with AFib?
Unfortunately, aspirin has been studied compared to warfarin as well as compared to the newer anticoagulants, and it is not shown to prevent stroke sufficiently to be considered an alternative at all. So it's unfortunate because it's very easy to get aspirin, it's very inexpensive, it's very easy to take, but it just unfortunately is not shown to sufficiently protect against stroke to be considered an option.
Okay, thank you. After an ablation, does the patient still need to be on medications, blood thinners, calcium or beta blockers, rhythm medicine, rate controllers, etc., temporarily or permanently?
So there's two parts to that question. One is looking at the blood thinner. And the blood thinner after an ablation is actually extremely important to be taken very regularly, especially for the 3 months after the ablation. And then after that, it actually all depends on the CHADS VAS score. If the CHADS-2 VAS score is elevated, meaning it's 2 or greater, they need to continue taking the blood thinner indefinitely. So the catheter ablation doesn't change the need for blood thinner. That is dependent on the patient's risk factors for stroke. As far as the rhythm controlling drugs, the antiarrhythmic drugs, sometimes we might ask a patient to keep taking the antiarrhythmic drugs after catheter ablation for a period of time. Typically, that's going to be about 2 to 3 months after the ablation. After that, once we've had a chance to sit down with the patient, we may then ask them to, or actually give them permission to go ahead and stop the antiarrhythmic drug, especially if we feel like the catheter ablation has been successful.
Was there a recent change in blood thinner recommendations considered to be CHADS score in women of 3 or greater?
So in Europe, actually, I think in Europe, they've removed the female sex from the CHADS-2 VAS score there. So I think that's why if you are being treated by a cardiologist in Europe and you're a female with a CHADS-2 VAS2 score of 3, they may actually have, through shared decision-making, decide not to give you a blood thinner. But here in the United States, the CHADS-2 VAS score still includes female sex as a point on the stroke scale.
And that is a complex question. I'll tell you, the old CHADS score, before it included a risk factor for being a woman and a risk factor for your age being over 65, I, as a younger cardiologist, had a bunch of women whose CHADS score, the old CHADS score that didn't include women or age over 65, who had strokes, devastating strokes, at 66 years old, and who at the time were considered to have a 0 CHADS score. And then later it was found that being a woman, unfortunately, is a risk factor for stroke. Eliminating being female as its own independent risk factor is controversial because some of the data goes either way. And I'll tell you, if it was me, if I was a woman over 65, I would take a blood thinner if I had AFib.
And everyone should really remember the statistics are statistics. So if you are saying 2% risk, 3% risk, I've had people tell me that seems like a low percentage of me getting a stroke, but it's not 0. And if you are in any percentage in the CHADS VAS score, well, again, that is why physicians like ourselves will, encourage and say, listen, there is still a risk to be not taking the blood thinner. So hence why, it's one of those where I've had patients just say, I don't believe that the score is putting me as high risk. I'm like, well, that's true. But the fact is, if you have the AFib, and again, it's in your heart, we know what's happening, there is a possibility of clot formation.
How much was the rate of stroke reduced when the appendage is removed?
Well, this is a kind of a loaded question because the rate of stroke, there's 2 types of major stroke, hemorrhagic and ischemic stroke. Hemorrhagic stroke, and basically is the bleeding stroke, the one that bleeds in your brain, and that's a real bad one, not that the other one isn't. However, that was reduced significantly with the Watchman device compared to blood thinners. Ischemic stroke actually can favor blood thinners because, as I mentioned in my talk, when you're treating one particular part of the body, that doesn't mean stroke can't exist somewhere else, like your carotid arteries, your aorta, your left ventricle. Being on a blood thinner treats everything. So if you took both bleeding stroke and ischemic stroke and combined them, the rates of stroke are actually decreased with the Watchman device because of the bleeding risk. So that's when I tell patients, if the risk of the blood thinner is high or you cannot tolerate it, the risk of doing the Watchman becomes lower, even if you know that the risk of ischemic stroke is treated a little bit more thorough with the blood thinners.
Okay. This person has clots in their LA appendage and they go on, but if they go on blood thinners, will the medication dissolve the clots? And if so, how long will that take?
Well, generally the blood thinners aren't meant to, there's certain medications we give like TPA during a stroke that can break up clots. But this particular situation would be the blood thinners would prevent more clots from forming and the body will absorb over time. So it can take months. In these type of patients, we oftentimes routinely retest them by looking at these the clots in their heart after they've been on blood thinning therapy. And if this medication doesn't work, we could oftentimes replace it with a different type of medication if needed. But this is not one of those situations where we would ever put a device in someone's heart if there's active blood clots that are seen on imaging.
Does insurance cover the cost of the Watchman if a patient is unable to take blood thinners? And if it does not cover the cost, how much is it?
Well, insurance does cover it. And number one, if they meet the indications. So there has to be clear-cut documentation by the physicians about their risk score, their CHA2DS2-VASc score, the presence of AFib, as well as the reason why they can't take the blood thinners. Out-of-pocket costs, I've had one patient ask me at that before, but to be honest, it would vary. I mean, I would think that easily 6 figures is what we're looking at for the hospitalization and the device. I would not suggest it for anyone to try to pay out of pocket for a device that is FDA approved and will be paid by Medicare and most insurance companies, if not all insurance companies.
Any concerns about the generic dabigatran now approved and widely available?
No, the generic forms of the blood thinners work great. This year, in fact, the generic form of Eliquis, apixaban, should come available in the United States. The company that originally made it sued to keep it on patent and on brand 6 or 10 extra years than it was originally planned to. But this year that runs out. So at some point this year, the generic will be available in the US as well, and people won't have to get it through mail orders, but we don't know when that'll be. And the generics, again, work exactly the same as the brand name ones.
I think you just answered this, but let's try it again. Can you get the Watchman device if you're willing to pay for the device without using insurance? You address that.
Yeah, and I would absolutely not suggest it because again, there's more to it than just the procedure. There's of course anesthesia. There's a hospital cost. There's so many other things that people don't realize during these type of things, and it's not something I would ever suggest to a patient. Nor would I actually perform a procedure necessarily if someone's trying to pay out of pocket. I'd really question the indication of why they're doing that.
Okay. Does the Watchman come in different sizes?
It does. It comes in numerous sizes, and basically the device has changed over the last 8-9 years, where it started out with maybe 3 or 4 different sizes, has gone as high as now 5 different sizes. We are seeing majority of people able to get the device, which is great. In the sense their anatomy are suitable, the devices can fit it. So it is definitely changing. I anticipate it'll just continue to change over the next few years because, again, the device, the goal of it is that there shouldn't be any patient that can't have this type of closure if they need it.
This person participates in extreme sports with high risk of falls and concussion, which could cause external and internal bleeding. With Eliquis, they're unable to participate in these sports, which is affecting their quality of life. Is this an acceptable reason for implanting a Watchman?
Well, I'll tell you, to be honest, I've had people literally say to me, I like to skydive recreationally. I don't need to be on a blood thinner. And I usually tell them, if your parachute doesn't open, a Watchman's not going to save you. So if you're doing recreational activities, honestly, that isn't actually affecting your work. Work is different. When I have had people say to me, I work in a high level machinery or something that is going to cause potential bleeding, that becomes a much more legitimate way of discussing. But when someone says it's a recreational activity, it has to be tempered with the risk of doing a procedure, because no procedure is without risk, and there are complications from everything we do. And if the complication happens, well, is it worth because you wanted to play a sport on Saturday and Sunday that was a little bit more physical? I'm not sure that's worth the risk. And that's why I like to believe each conversation has to be patient specific. I don't think you can just say globally, nobody who has this type of lifestyle can't get it, but I do feel it has to be a conversation on one-on-one.
It's also maybe worth noting that taking a blood thinner doesn't eliminate your ability to do any sport. People still ski while they're on blood thinners. In addition, the effects of blood thinners are reversible. There are infusions people can get, medications that they can be given to, if God forbid they have trauma and they're on a blood thinner, to reverse the bleeding effects of the medication. So it's not like any accident you get in and you're on a blood thinner, you're immediately going to die of bleeding because nothing can be done. There's a lot that can be done to reverse the effects.
Do you always do an ablation before doing the Watchman?
So typically what we do here at Boulder Heart is the ablation is done first, and then about 4 or 5 weeks later, the Watchman can be performed.
Should patients with AFib exercise regularly?
Yes, actually it is part of the lifestyle modification that we recommend to help patients with paroxysmal AFib and persistent AFib. Typically, it's at least 30 minutes a day or 210 minutes a week. That's actually what we recommend for all patients to help control their AFib in the long run.
And as we talked about in the talk, doing no exercise if people find themselves unable to exert, or doing intense exercise. So high level cycling, many hours a week, very intense exercise, 50-mile bike runs, a marathon every weekend. Those kinds of activities are associated with much worse AFib. So that baby bear Goldilocks zone of exercise in the middle, where you're getting 2 to 5 hours a week of moderate intensity exercise, that's the zone that decreases both AFib and many other adverse heart effects.
You did describe the diagnoses for a flutter and an AFib. Is there a difference in how it feels?
It's a good question. There usually is actually a difference. Atrial flutter is typically a very stubborn rhythm that once it locks into a certain rate, typically is very difficult to come out of unless you have a cardioversion. Now, the way the patient experiences that can be in very many different ways. Fatigue, palpitations, shortness of breath, chest pain. But the arrhythmias do behave very differently. AFib is an irregular rhythm and can be rapid sometimes and slow sometimes, whereas atrial flutter tends to lock in at a certain rate usually. But even with atrial flutter, sometimes the ventricular response or the rate can be variable as well.
Does it hurt a lot during the healing time when the Watchman is being absorbed and integrated into the body? And how long does it take for the body to accept the device?
Well, there's really no pain at all associated with the procedure as well as the recovery. Usually it's just the area of the groin that may have any issues post-procedure immediately. Oftentimes, it can take a few months for the endothelialization of the device into the heart. But again, I have actually firsthand seen other patients who have had open heart surgery for other reasons who have had prior Watchman. And I will tell you, it's quite amazing when you can see the pictures of the device being absorbed. So it really does get absorbed by the heart wall muscle. And it is one of those things where there is no scarring per se, or feeling of scarring or pain. Most people who have this procedure don't even know that they've had it. So that's basically what we're looking for. We're not looking for any major symptoms, good or bad, to change after the device is placed.
This person has had 2 cardiac cath procedures for stent emplacement via the wrist. Can those cath procedures be done also through the wrist?
Ablations are not done through the wrist. They're done through veins rather than arteries. And we need veins that can dilate and accept several different catheters to get where we need from the angle we need. So we don't do the ablations through wrist veins. They're not big enough veins to do the procedure.
Okay. Why do you still have to be on blood thinners after ablation? If it has a 75% success rate, can't you just watch it?
It's because of that other 25%. It's unpredictable, and we never consider AFib cured. AFib can show back up after someone has had resolution of all their symptoms following ablation for years, and it can present as a stroke. So if we base entirely the blood thinner on your personal risk of stroke, which we calculate in every individual person. And if that risk of stroke is more than 2% or so per year, based on that score we've talked about, then we recommend keeping people on blood thinner.
Stroke alert activation, emergency room 11, now. Stroke alert activation, emergency room 11, now.
So in summary, because we can't cure AFib, if people have a risk of stroke, AFib can always recur. It can show up as a stroke, so we continue the blood thinners to prevent future stroke. Atrial flutter is different. Usually we can cure atrial flutter. And if we do a flutter ablation and people don't also have atrial fibrillation as a rhythm, those people come off of blood thinner around a month or 3 months after the ablation and don't need to be back on the blood thinner. But AFib is a different rhythm that can, unfortunately, even with our best efforts, can recur. So that's what we base that decision on.
Do you recommend taking metoprolol as needed when AFib is present or on a daily basis?
You know, a lot of that will be up to the discussion between the patient and the doctor. Some patients can't take metoprolol every day because it makes them feel fatigued or tired. It can be taken as needed, but it's important to understand that metoprolol is not an antiarrhythmic drug. Metoprolol can slow down the heart rate. It can shield the heart from the sympathetic.
Stroke alert activation, emergency room 11, now. Stroke alert activation, emergency room 11, now.
So metoprolol as a beta blocker can shield the heart from the sympathetic influences of the body, but it is not designed specifically to convert atrial fibrillation.
Post-procedure and post-follow-up, do you recommend that the patient wear an Apple Watch?
The Apple Watch is actually pretty useful to help detect episodes of atrial fibrillation or any other arrhythmias for that matter. And I think it does have a role to play, especially in patients who have AFib symptoms that occur rarely or not very commonly. The monitors that we have here can be worn for 3 days, 1 week, or 2 weeks. But if episodes are happening less frequently than every 2 weeks or every other day, then an Apple Watch can be useful to help us determine those tracings. The tracings are actually quite valuable. Sometimes we can review those tracings with our patients. They can send them through the portal so that we can look at them. But we don't routinely recommend an Apple Watch after every ablation. That's usually going to be patient-specific and tailored to different situations.
Is ablation more risky if one has mitral valve valve prolapse?
No, mitral valve prolapse is not uncommon in people who have atrial fibrillation, and it doesn't add risk to doing the ablation procedure.
Do you recommend everyone over 75 get an electrocardiogram?
I think an electrocardiogram can be part of the screening that a primary care physician does with patients. And yeah, definitely as patients get older, an EKG could be very useful to help diagnose arrhythmias that may be asymptomatic. And one of those arrhythmias can be atrial fibrillation.
When you have an ablation, is there a loss of heart function?
When you look at the ablation we do for atrial fibrillation, it's actually a very limited ablation around the pulmonary veins targeting the muscle sleeves. These muscle sleeves that we target actually play no role in the overall heart contraction. The muscle sleeves that we target during an ablation for AFib are muscle sleeves that have grown into these veins, and because of their abnormal anatomy there, behave abnormally. But by targeting these pulmonary veins, there is no impact at all on the left atrial function. Now, in some patients, they end up getting a more extensive ablation. They could end up getting a more extensive ablation that includes the back heart, the posterior wall of the left atrium, and sometimes other ablation lines are delivered in order to control other atrial flutters that may be mapped during the procedure. And those patients sometimes, if there has been a lot of scarring in the heart, as caused by ongoing atrial fibrillation or extensive ablation, can develop what we call stiff left atrial syndrome, and that sometimes can contribute to some shortness of breath or fatigue.
Has the ablation procedure changed in the past 7 years?
7 years? We, in the talk about what we do for AFib ablation, we included all of the safety measures that we use. And our ability to generate images of the heart, to avoid needing to use a lot of X-ray or what we call fluoroscopy has improved greatly. The ability to picture where we're putting the catheters into the veins and how we move them in the heart. So all the risks of fib ablation, which was first done 25 years ago or so, have diminished greatly over the years of using the same technology. So that's a big way, especially what we call mapping system, that the procedure has changed. There's also a new form of energy to treat atrial fibrillation that doesn't generate heat or freezing, the two other ways that we've traditionally done it, but it pokes holes in cells. That was released just within the year as an option for folks, and docs who are kind of brave and patients who are kind of brave, who are willing to have the first generation of this new modality, which is called pulsed field electroporation, or PFA, have been having that done. It's still in studies. We're still finding safety things we don't know yet how to prevent. So people ask us a lot if we're doing PFA, and we will start doing that once we know more about the safety and the catheters get a little bit better, and we know how to prevent certain risks that we have seen early on. So that's been a big development over the past couple of years, specifically the last year.
Okay. We have just time for just a few more questions here, and then we'll wrap it up. Will a blood thinner be detrimental to wet macular degeneration?
No, there is no
Macular degeneration.
no interaction between a blood thinner and macular degeneration.
Okay. And to get a prescription for the less expensive Eliquis from Canada, do they come to you, or how do they do that?
People can look this up on their own if their other doctors are prescribing the Eliquis, and they can even kind of educate their own doctors about it. We have people go online to and essentially search for Canadian mail order pharmacies, and then you'll get a bunch of them, and they all have a little window, and you can type in the medication that you want to get, and it will immediately tell you the cost. In that case, people will then sign up for one of these mail order pharmacies. They create an account with their information, like their address and their age, et cetera. And the other thing the patient enters is their doctor's office. And then the mail order pharmacy contacts us, and then we submit the prescription straight to them.
There's a lot of athletes that were athletes as they were growing up, and through college, they may have backed off from that high level now. Does that pose a higher risk to them?
It does. Deconditioning, which sounds like kind of a mean term, but going from like highly competitive NCAA sports competition to backing off to a more moderate level of exercise does help decrease your risk of having atrial fibrillation. Folks who continue to compete at a very high level, like continue to race, pro cyclists, people who are still high level performing as time passes, unfortunately, they're at very high risk of having atrial fibrillation.
And there's nothing you can do once you've been a high-level
It depends
athlete.
on the stage of the rhythm. So we often offer those people ablation, and sometimes they do great. But if we get in there and we find that their upper chamber is already been scarred and stretched, from intense conditioning, intense exercise over many years. Sometimes even multiple ablations aren't enough to control the rhythm. So we like to intervene sooner than that.
Okay. Thank you for tonight's lecture and the question. We have come to the end of the time. A recording of tonight's lecture is available at bch.org/livestream. You will receive a post-lecture survey by email. Please take a minute to fill this out. Thank you for joining us and have a good night.